For those in the room and for those participating virtually, we're going to go ahead and get started with our next panel, which is like a two-parter, the first of which is on everybody's favorite topic, interoperability. And I'm pleased to invite Susanna Fox and all of the other panel members to come to the stage.
Come on up. Oh, good, I'm live. Good afternoon, everyone. Welcome back. We're just, let's use 4. We're not going to keep a seat for Elijah. So welcome back, everyone. We are going to focus this panel on interoperability. And when I was asked to moderate this panel, I was really excited because we have 4 experts on different aspects of interoperability and the challenge of it within the context of privacy and security. And I wanted to open by saying that, so I'm Susanna Fox, I'm the Chief Technology Officer here at the US Department of Health and Human Services. And you might ask, what is it that the Office of the Chief Technology Officer has to do with the idea of privacy and security and interoperability? And what I would say is that interoperability is actually truly about improving the basic services that we deliver through electronic health records. And what it's going to take in many ways is not just a change in technology, but a change in culture. And so in bringing that spirit of innovation and change to this discussion, we as a panel decided to actually host sort of a fake awards show. And so you can see, we're going to get the slide up in just a second, of the panelists. And what we're going to do is actually give out 2 imaginary awards. One is a seedling worth saving in the spirit of spring. What has significant potential but is in danger of being starved, stepped on, or planted in the wrong place? And then the other award that we're going to give out today is what is ready to harvest? What should we not only celebrate and admire, but also propagate widely? And what I would encourage all of you to do is use Twitter to join the conversation and use the hashtag and tweet at me as well as the other panelists. And my goal here is actually to get a debate going. So we're going to leave some time for people from the audience to contribute maybe some awards that you want to give out as well. So I will now introduce our really fantastic panel, and I ask people to give me essentially a one-liner about themselves. So I'll start to my left. Anna McAllister-Slip is the co-founder of Galileo Analytics, and her description of herself is a frustrated patient turned health IT entrepreneur, passionate about the ability of new data sources to improve understanding, research, and care. Next is Drew Schiller of Validic. He's the co-founder and CTO at Validic, focused on pragmatic interoperability. Next, we have Christina Hyde, Senior Advisor for HIPAA Policy in the Office for Civil Rights here at HHS. She develops regulations, guidance, and policy to protect individuals' health information and privacy rights. And last, we have Asia Brooks, a privacy policy analyst in the Office of the National Coordinator for Health IT. And she has 99 problems, but HIPAA isn't one. So I'm going to start actually with the first award. What is, and I'll go down the line, and then for the next award, I'm going to start with you, Asia, and come back. So what, for example, is a seedling worth saving in the context of interoperability?
One thing that I'm a part of, I'm actually on the board of a group called Share for Cures, and it's a nonprofit organization that's really doing interesting things, but they are struggling because they had a pledge from a large foundation for a substantial amount of funding to get up and going. That was canceled after the PMI was announced in January of 2015. So this is a group, it's made up of researchers, informaticists, many of whom used to work with the ASCA and were building a learning health system there and prototype. They left there out of frustration and started a nonprofit focused on the same thing. And it's all about giving patients the ability to access and exchange their data and then to share that research, to share that data with researchers. So it's a really important movement. It's a really important function. And it's something that I think is sort of like step one in interoperability and getting individuals access to the data they need so that they can then share it or incorporate it into other platforms or other tools and, you know, at least have the data interoperable.
And in this situation, what we're seeing is that that's a seedling that got starved, that they're getting starved in terms of funding. And so your call would be to say, look for those things that might be starving because the attention went to precision medicine, but really could have a significant effect.
Yes, and I've actually seen that in a couple of things that I'm involved with, where there's so much focus on the Precision Medicine Initiative, which I think is brilliant and important, and I'm very much supportive of. But there's a lot of confusion amongst foundations, private sector organizations, corporations who are very supportive of the goals of the PMI, but they don't want to fund nonprofits or other companies like startups because they're afraid they don't really know what's happening in sort of the marketplace around these kinds of initiatives. So I think it's important that we encourage the foundations, companies, that they need to invest in these seedlings and these good movements so that they can thrive and play their role.
All right. Okay, great. So, Drew, what is a seedling worth saving?
Yeah, I'm actually going to change my response from what I had initially thrown out there. Similar to, it's in a similar vein, but so on the Precision Medicine Initiative topic, I think that if I'm extrapolating your point to one that I'd like to make is that there's going to be a lot of different individuals that make up the larger PMI, or a lot of different groups. And so one new group that just started, kicked off in Q1, is an organization out of Mount Sinai, New York, called Node Health. And effectively what they're trying to do is become a data repository and knowledge sharing for clinicians who are doing work in digital health evidence. So we all know that you know, a lot of work is being done, obviously, on patients in the clinic, but that most of life happens outside the four walls of the health system. But in order to actually provide care and ultimately a value-based reimbursement system where we're incentivizing patients to be healthy and live healthy lives outside the four walls, we actually need medical evidence to show that certain treatment protocols work. And so what Node is trying to do is create a situation where all of the physicians can leverage all of the work that other clinicians are doing throughout the country to run multi-site studies, to build on each other's work instead of replicate each other's work. And it's a really great initiative that I think I only say it's worth saving because it's only just started. So it hasn't been stepped on yet, but please let's not trample it before it gets a chance to grow.
Great, great. Christina, a seedling worth saving.
All right, thank you. So as you heard, I am with the Office for Civil Rights, and we have the awesome responsibility of administering the HIPAA privacy, security, and breach notification rules. And I think I heard a suggestion in the last panel for an additional rule, which was a business leader implementation rule, which is certainly something we can consider as we move forward. But I thought, given my role, that I would take this opportunity to spend a little time focusing on a very important aspect of the HIPAA privacy rule, which is an individual's right to access their health information. And this has been around a long time in reg years, although not compared to some of the stuff that's been in the common rule around forever. But it's certainly been around for a while now, and it's a long-standing and fundamental right, but with significant, to use the words of the award, significant potential, certainly in our eyes, but really just barely tapped into that so far. And so there's so much more we can do with that. And even though it's been around a while, it's certainly there are some potentials for it to be starved and stepped on. As you may know, we issued guidance in early 2016 to clarify various aspects of this important right. Pretty significant guidance, covering everything from the scope of the right and how broad it is, as well as onto other things. And that was issued in response to some misunderstandings we had heard over the years, as well as what we came to realize was that the rules in this area were being implemented in manners that perhaps OCR had not intended. And there were resulting barriers to individuals being able to access their health information and to exercise this important right. And I'll raise one area, which is the fees that were being charged to individuals and may be charged to individuals to get a copy of their health information. And as you may know, this is the HIPAA privacy rule itself contains some provisions for fees that may be charged. We did our best in what we could do in the guidance to clarify the bounds of that. But certainly there is still the potential for a barrier here. We laid some ground in the guidance, or put some stakes down, if you will, in the ground that we really think of the access right and individuals' access to their health information as an essential part of healthcare delivery. And that because of that, we really believe that despite the fee provisions in the HIPAA privacy rule, that copies of records should be provided free of charge, so that this is a right for everyone and not just those who can afford it. And we also, I guess, cautioned would be the best word, that we would continue to monitor this area very closely. We would take enforcement action where necessary. And we would also reassess those provisions in the HIPAA privacy rule to the extent that there continued to be barriers to individuals accessing their health information.
Great. So a seedling worth saving, Asia.
My seedling worth saving, I chose back to the basics messaging. And a lot of folks would probably ask, what does that have to do with interoperability? That's too simple. Well, I use my father as an example. My father suffers from PTSD. And so if I have anything that I want to explain, or anytime I'm trying to educate people about electronic health records and what they do, I always test it on my dad. So I said, Dad, you're going to church Saturday, Sunday, Monday, Tuesday, Wednesday, every day. And he has a men's group. And in his men's group, I asked him to say, hey, Dad, ask folks in your men's group, do they even know what an electronic health record is? Only 2 people. And the 2 people that knew what an electronic health record was were the 2 folks who had a recent surgery. So the reason why I wanted to bring the back to the basics message back, and I think it's starving a little, is a lot of folks don't even know why it's important. So before we can get to building our learning health system and using or optimizing the infrastructure toward interoperability for those, for the individual as well as population health, we have to make sure that our demographics understand that this is important. And the way that I was thinking about this was just like, hey, most people know if you drink and drive, that's bad. Don't do that. You don't want lead in your water. That's bad. So I am trying to think of a way that we can talk about electronic health records, but in a way that the masses will be able to understand its importance and why. So there's 2 examples I like to give. One example is for the individual level, where I explained, I said, hey, Dad, would this make a difference to you? And I talked to him about a lady. Her name was Julia, but it's not PHI, it was out there on Earth, so just in case. But she wrote an article about how she was going in for a back surgery. And before she went into back surgery, she found out that her doctor said, oh, you know what, in your electronic health record, it says here that you haven't been checked for a mammogram. She was diagnosed with stage 1 breast cancer. She credits that EHR for saving her life. So I told him about that on the individual level. So he said, hey, I understand that. Another good example at the population level is, all of you have heard about Flint, Michigan and the issues there with the water. So because of the EHR, that pediatrician, when she was checking the levels of lead in the children's blood, that's how she was able to determine that there was an issue. So think about it, an EHR system, I'm not telling you which one, but an electronic health record system helped discover that there was a problem among the demographic or children in Flint, Michigan. So I think about optimizing and using some of that data, but also trying to narrow it down to the lowest common denominator so people understand why it's important.
I was just going to say, what I asked these guys to do, I said, this will be a successful panel if we start to disagree with each other. You can agree, but I'd love to see if anybody has feedback on any of the awards that we've just chosen.
Yeah, so a couple things. But so Asia, first and foremost, I think that the point, there's an underlying point. So your dad and his men's group, when he was asking them, the only two folks who knew about EHRs were the folks that recently had to leverage them. And I think this is the single biggest challenge that we have in healthcare, which is that nobody wants to ever be a patient. There's never a chance. There's never a time where we want to actually participate in healthcare until we have to, right? And so I would almost argue, I don't know if it's, I think that the biggest win here would actually not be to mass educate everyone on the importance of EHRs, but to make it to be something where it's just understood that data flows in healthcare and there's nothing that a patient would have to do. And I mean, that would be the win, right? The win for me would be to be able to go to my doctor and then, you know, go across straight lines and go to another doctor and my data is just there. Like, I as a patient don't want to know that I have a right to access my data. I just want my data to flow. And so that's the ultimate, and I think that's the ultimate goal, but that's the lens that I want to look at it through. I think that the patient empowerment concept is really interesting, but what I really like to get to is beyond that and just have a better patient care to the point where the patient doesn't even have to worry about it and it's just done for them.
Oh, it makes sense.
And I would agree completely. I mean, you know, I did not start out life wanting to get into health data information or health data analytics. I can assure you that. I got into it because I had to, because I was frustrated with the slow pace of research and the slow pace of using electronic tools to come up with better outcomes measures. And we don't want to focus on electronic health records. My husband really would love it if I stopped focusing on electronic health records, as would most of my friends. And I think that we need to be able to walk and chew gum at the same time. I mean, it's not we need to educate people about the importance of this stuff, but I don't think that that should preclude us from focusing on the critical, you know, social, political, moral, structural, and technological issues that are stopping us from interoperability.
I have one little rebuttal. I think when it comes to, and a small disagreement, but this is good. I think when it comes to making sure that we get there, I think you're a part of my learning health system. That's where I want to be. However, right now, people aren't getting the information they need. So in order to empower them as a public servant, it's my job to serve someone who says, hey, I can't get this. What is it that what are my rights? And so that's when I go over and say, enforcer, my hockey person over here, and say, hey, what's the access guidance? Why shouldn't they be able to get this, or why can they get it, or can we or can't we? So right now, I need an enforcer. I need her. Then, as we progress, I can say, hey, this information should just flow. But until then, it's just kind of like we're just that modular step in between. And so I think that kind of like the business guy out there, hey, in order for people to take up something, you need a demand. And so right now, it's just kind of like a sitting thing where we have this technology, but it's not necessarily being utilized or optimized. In order for that to happen, from my perspective, we need to really engage patients and the healthcare industry as a whole, but some way that we can break this down that's very simple, that we can say, hey, this is why this is important, and that even includes research. Like, hey, you know what, we could be, I don't know, 15 to 10, 20 years out if everyone turned their data over for research, de-identify. But think about that, like what could we do to encompass your message, but as well as make sure that we're not dropping the people that need us today.
Yeah. No, I actually, so I do have a question on the enforcer really quick.
Yeah.
So
I get that a lot.
Yeah, I'm sure you do. I'm curious the distinction that you make between patients' right to access and forgive any naivete that I have here, but the actual who owns patient data, right? So this is decided state by state. Right now, like New Hampshire's ruled that patients own their data, but beyond that, most states have either not ruled or have claimed that the physician owns the data or the health system owns the data. So how do you reconcile that with the right to access?
Well, that's the beauty of HIPAA. HIPAA doesn't care who owns the data. The individual has a right to access their data, regardless of who may own it or what the laws say about who may own it. If it's held by a healthcare provider or health plan subject to the rules, the individual has a right to see it, to get a copy of it, and also very importantly to direct that copy to whoever they want to. And so, you know, ownership is not what we should be focusing on. It's the right of the individual to get access to their data. And from your prior comments, thank you. Yeah, see. And sometimes they do clap when I speak, even though I am the enforcer. You know, your prior comments seem to focus on getting data from health system to health system and provider to provider, which is of the utmost importance, but it's also very much about, and interoperability is very much about having the patient in that loop and having the patient get access to the data and being able to get their caregivers access to the data and being able to donate their data for research purposes. So the individual plays a very big role in this. They're not just a patient. They are people who want to take control and manage their own health care. And that's fundamentally what the HIPAA right of access is about.
All right. Oh, please, go ahead.
I was just going to say, I tend to agree with you. I mean, I know you're just speaking about, you know, from the perspective of HIPAA and how HIPAA deals with ownership. For the vast majority of people that I talk to about these issues, and certainly the way that I feel, I don't honestly care who owns it as long as I can access it and use it. And I can know who else is accessing it and using it. And have the ability to, you know, either tell them to stop using it or, you know, to publicize the fact that people are doing what I think are unethical things with my data. For me, it's really all about usability and being able to not just see the data, but to be able to get it in a structured, machine-readable format and a constant data stream that I can use to care for myself, or that I can use to care for my family, or that I can use to care for, you know, to donate to researchers. I generate lots of structured, machine-readable data that goes absolutely nowhere. I can't use it for myself. None of my friends can use it, and I can't donate any of it to research because we don't have interoperability.
Yep. All right. So our next award is going to be for what is ready to harvest. And this is the idea that what should we not only celebrate and admire, but really propagate widely. So this might be something that's well recognized that you just think should absolutely go global. So I'm going to start at the other end and then come this way. So please start.
Thank you. What I would like to bring attention to is, I'm keep picking on you, but the HIPAA privacy rule has permitted uses and disclosures, and it seems like to me folks have forgotten that it exists. So, and what I mean by that are permitted uses and disclosures are instances or times when between covered entities, they can share different types of information. And what I found as working in ONC is that a lot of times folks will call and say, hey, well, we don't know to whom or for what purposes we may send this information. Can I or can't I? And I'm like, hey, I'm not the enforcer. I'm not the OCR person. I'm just the ONC person, so I'm guessing you should be asking me questions about high tech, but generally, it's just back to the basics of what can you send and what can't you. And to me, having a basis of knowing what those rules are may help. So an example of this would be, a lot of times you say treatment payment in healthcare operations, people are like, oh yeah, I know what that is. And then I say, okay, tell me a healthcare operation. I don't know. Well, I kind of know. And then I'll say, oh, well, what do you think about, oh, well, Asia, can I send this information for quality improvement? HIPAA privacy rule, permitted uses and disclosure. Asia, can I send information that talks about downstream treatment from another provider? That's in the HIPAA privacy rule. It's permitted. Or another, so there's a lot of examples where you're able to send information between covered entities, even in certain instances or circumstances where I might be using the information of another provider for my own use and they have to send me something else. So there's always going to be a disclaimer about how you can receive and retrieve that information from another provider or covered entity. But to me, that is one of the most under-celebrated portions of HIPAA, is that it actually enables interoperability with the rules, because generally the things that we need in order to orchestrate or administer health care, it falls within one of those permitted uses.
All right, so I'm going to just say again that we would love to hear from you if you guys have nominations. So thank you, Adrienne. I knew I could count on you. So I'm going to ask the three other panelists to be quick so that we can get to the audience.
I guess I would touch on something I've already touched on, which is the part of the aspect of the HIPAA right of access, which is the individual's ability to direct the entity to send a copy of their information to someplace else, to another provider, to a researcher, to a caregiver, to an app, to a data aggregation service, wherever they want it. And this is an important aspect of the right. It's newer, circa 2009, and so, and then implemented in the rules in 2013. And so, but it's something I think that should be celebrated and propagated widely. And we did spend a good amount of time, we gave it quite a bit of real estate in our access guidance so that we could spread the word about this and ensure that patients knew they could leverage this for many different purposes. And we've been talking about PMI. This is certainly one way that individuals will be able to donate their data into the PMI, which is obviously a presidential and administration priority. So.
Great, thanks.
Mm-hmm.
Mine is short, so certainly to celebrate and admire FHIR, I think, and also let's get on with it already and just make it something that everyone has adopted. And I mean, I will say, one of the amazing things about FHIR is that it is very, very grassroots. It's grown organically, and for very, very simple reasons. It's just easy to use, and it's something that technologists actually want to adopt. So I think the success of that is just really down to the basics.
I would say here to that. What I would really like to see grow and what I think is ready to explode, and I think we should all support, is something that I've been a part of for the past couple of years. It started in the type 1 diabetes community, and it's a hashtag movement. And yes, I kind of resent having to use the word hashtag movement in adult conversation. But it's a hashtag movement called #WeAreNotWaiting, and it's really comprised of a group of individuals. I mean, I'm part of the movement, but I'm not a real technologist. I just play one from time to time at boring cocktail parties. But this is a group of people with type 1 diabetes who have children with type 1 diabetes who, ahead of FDA, ahead of the companies, took the technological skills, they're computer scientists or technologists from one form or another. They hacked into the devices that we all wear, figured out how to access the data. And for those of you who don't know, insulin can very easily go very wrong, and 1 in 20 people with type 1 diabetes die from an insulin overdose, even though they're doing everything absolutely right. So these parents figured out how to follow their children's blood glucose monitors from afar. And they just did it because it was something they needed to do. And they changed the life of many people with type 1 diabetes. And now they have a Facebook group. I think there are now 17,000 members of this Facebook group. They're now in 27 different countries. They're sharing their code on GitHub, and they're making it available in a very easy-to-use way so that anybody can access this data, can access their child's data from their continuous glucose monitor, follow them from afar, and keep them safe while they're at soccer practice, sleepover, summer camp, whatever. And the same group of people, many of the same group of people, have gone one step further, and they've created an interoperable artificial pancreas comprised of an old insulin pump, a continuous glucose monitor, and like a $40 circuit board that you can buy on Amazon called a Raspberry Pi or now an Edison. And they are dosing themselves automatically using the data from their CGM. And it's brilliant. Their numbers are absolutely stunning. I would love to have those kinds of numbers. And it's way ahead of the traditional process that we've come accustomed to. It's way ahead of where FDA is. It's way ahead of where the companies are. This is not research. This is not based on clinical research. It's based on the fact that these people are desperate. They're tired of living in danger, and they knew how to use their skills and take advantage of the technology that does exist. And I think this is one of the most exciting things that's happening, and I'm wrapping up. I think it's one of the most exciting and important movements in the digital health space today, and I'd love to see it grow and spread into other diseases.
And what I love about this panel is that we really do have a mix of government, private sector, and pitchforks. And speaking of pitchforks, I'd love to hear from the audience.
And it's not a pitchfork, surprise. I want to offer a definition of interoperability and hear the reaction of the people on the panel. And the definition would be independent decision support at the point of care. So an EHR would be interoperable if I, as either a patient or a physician, because many physicians are employed and behind systems that they don't control, could access independent decision support, whether it's Watson or GoodRx or anything in between, at the point of care as becoming the goal, whether it's a 10-year goal or a 3-year goal, we can argue, because that would drive a lot of what's going on in the development of FHIR, which frankly I'm quite worried about, that it is going to be short of achieving that goal if we don't establish it. And if there's something wrong with that as the definition of interoperability, I'd like to hear from people who know.
All right, and this is actually going to close us out. We can keep talking on Twitter, so if people have tweeted their own reactions, that's fantastic. So a reaction from any or all of my panelists.
Well, I'll defer to others on the technical aspects, but I'm for patient access to data, to their data, so.
I would disagree in the sense that I think that if we get true interoperability, not just with EHRs, but also with medical devices, that the point of care begins to happen automatically. And that it's more about, point of care typically is when you see your physician or when you are in the emergency room or whatever. My point of care is 24/7. I'm making decisions 24/7. It would be really great if we could have interoperability and ultimately people who are smarter than me could develop algorithms that could do that stuff better than I could, so that it truly is a seamless experience, both as a patient and for caregivers who are working with people like me.
Yeah, so I actually really like the comment. And I think that it is an outcome of interoperability, and it's something that can leverage it. But what I like about it is that I think that we should be looking at incentivizing the desired outcomes of interoperability and not the interoperability itself. And so taking from that perspective, I really like that concept. I think interoperability is a how, and I think that the ability to leverage it for real-time clinical decision support is a fundamental what. Like, how do we actually provide, like, what can we do to actually provide better care for patients and better experiences for physicians? And so if we can incentivize those what's, then I think the hows of interoperability will happen naturally.
All right. Well, thank you very much, and thank you to the audience. Sorry, Charles. So I'll just pause and say we're going to switch the mics, so talk amongst yourselves until we switch the mics.